Hello, everyone. Today, our team is thrilled to present our analysis of the multimodal healthcare system in the United States. This presentation aims to delve into the complexities and the unique feature of the U.S. healthcare system, examine its historical evolution of operational framework, and the pressing health issue it faces today. We hope to provide insight that not only inform but also provoke thoughtful discussion on the future of healthcare in America. The U.S. healthcare system model, known for its multimodal approach, this model, originating in the United States, skillfully combined elements from both single and multiple payer and provider systems. It integrates private insurance, government-funded programs such as Medicare and Medicaid, and direct care service. This fusion allows for a diverse range of healthcare delivery methods, which are strategically designed to meet the varied needs and preference of the Americans. The U.S. healthcare system began primarily as a private Medicaid medicine, major turning point including the 1960s introduction of the Medicare and Medicaid aimed to provide comprehensive healthcare coverage to the elderly and the economically disadvantaged. The adoption of the Affordable Care Act in 2010 marks another significant milestone. Expanding access and making healthcare more inclusive, these changes were driven by a need to adapt to demographic shifts, economics pressures, and evolving healthcare needs, reflecting the dynamic nature of the United States healthcare landscape. To understand the healthcare system fully, it's essential to consider the backdrop of the United States itself. Located in the North America, the United States covers approximately 9.8 million square kilometers, making it one of the largest and most geographically diverse countries in the world. From bustling urban cities to rural landscapes, the geographical variety is vast. The United States is home of melting pot of cultures and demographics, each with distinct healthcare needs, influencing how healthcare policies and systems are designed and implemented. Analyzing the U.S. healthcare sector through a pastoral framework provides a comprehensive understanding of external factors impacting it. Politically, healthcare is often at the forefront of national debates, influencing elections and policy reform. Economically, the United States spends a significant portion of its GDPs on healthcare, yet faces challenges like high cost and disparities in access. Social factor includes an aging population and prevalent chronic disease, pushing for innovations in care. Technological advances offer new possibilities for treatment and management of health conditions, yet raise questions about equity and accessibility. Legal aspects, including regulatory frameworks like HIPAA, play a crucial role in shaping operations and ensuring privacy and compliance. Environmental considerations, such as the impact of climate change, are increasingly recognized as critical to public health planning. Let's highlight the primary health challenges faced the United States today. Heart disease remains the leading cause of death, linked to both genetic and lifestyle factors. Obesity is a major concern, affecting nearly 42% of adults and contributing to the range of other health complications. And diabetes also poses a significant burden, impacting millions and straining healthcare resources. Addressing these issues is crucial for improving health outcome and reducing long-term healthcare costs.
There are three key entities that govern the healthcare system in the US, which are the federal government, state governments, and private sectors. First of all, the federal government, through agencies like the Department of Health and Human Services, oversees critical functions in national health programs, including Medicare and Medicaid. Meanwhile, each state has its own Department of Health, which administers public health programs and regulations. State governments also regulate private insurance within their borders. In the private sector, insurance companies, hospitals, and pharmaceutical companies play significant roles. Their decisions impact everything from insurance coverage to the cost of healthcare services and products. The federal government provides health care insurance through Medicare for those 65 and older or younger individuals with certain disabilities, and Medicaid for eligible low income individuals and families, as well as through military and veterans health programs. State governments manage Medicaid programs with federal support and regulate private insurance markets. They also run their own public health insurance exchanges under the ACA. At the federal level, policy frameworks include the ACA, which aims to increase health insurance coverage, and regulations on pharmaceutical and medical devices via the FDA. Agencies like the CDC and NIH set priorities for public health and conduct research to guide policy and practice. States determine additional public health priorities and initiatives tailored to their specific health challenges, such as tobacco control, obesity prevention, and vaccination programs. They also decide on Medicaid expansion under the ACA. And the federal initiatives, such as those led by the Office of National Coordinator for Health Information Technology, promotes the adoption of EHRS and supports the development of HIES. States may implement their own initiatives to encourage the use of telehealth, especially in rural areas where access to healthcare providers can be limited. They may also develop state specific technology solutions, such as databases for health services, and innovate in the application of technology in public health responses. In the United States, the debate over social justice versus market justice orientations in healthcare highlights fundamentally different philosophies about how healthcare should be distributed, who should pay for it, and what role the government should play in ensuring access. Advocates of social justice believe healthcare is a fundamental human right and should be accessible to all, regardless of one's ability to pay. The orientation also argues that the government should ensure universal access to healthcare services, often through publicly funded programs. However, from the market justice perspective, healthcare is a commodity in a free market system where access and quality are dictated by market forces like supply and demand. Proponents believe individuals are responsible for securing their own healthcare based on personal effort and financial ability. So, from our research studies, the US healthcare system is largely built on market justice principles, where private healthcare insurance and healthcare providers dominate the market. This results in a variety of insurance products and care options, but also significant disparities in access and quality. And according to the US Census Bureau's data from their latest reports, about 92% of people in the US were insured in 2022, and 65% of people were enrolled in private plans, while 36% were enrolled in public plans. So, among those who were enrolled in private plans, about 50% of the population was covered by employer sponsored insurance plans. For those who were covered by public plans, about 18.8% of the population received health coverage through Medicaid. About 18.7% of the population was covered by Medicare. So under the ambulatory care, primary care is typically covered across all types of insurance, including preventive services, which are often covered without copayments due to ACE mandates. Specialty care is generally covered, but may require referrals or pre-authorizations, especially under Medicaid and Medicare. Diagnostic services are covered by most health plans, but the extent of coverage can vary. Deductibles, payments, and coinsurance may apply. Prescriptions are widely covered, however, the formularies and out of pocket costs can vary significantly between plans. Medicare Part D covers prescriptions, although with a notable donut hole in coverage. Inpatient care is covered by all types of health insurance, but the coverage level and out of pocket costs can vary. Medicaid and Medicare cover inpatient care, including necessary surgeries and hospitalization. Mental health and behavioral health coverage has improved under the ACA, which mandates coverage for mental health and substance abuse disorders, similarly to physical health coverage. However, gaps remain in the availability of providers and services. Long term care is not typically covered by Medicare or most private health insurance plans. It is available but must be purchased separately. Adult dental, vision, and hearing care are not covered by Medicare and private health insurance as well, unless specific additional coverage is purchased. For cosmetic surgeries, procedures deemed non medical are generally not covered.
Now let's evaluate the performance of the US healthcare system, which is characterized by high cost, mixed outcomes, and unequal access. The United States has the highest healthcare costs among all OECD countries, spending an estimated 16.6% of GDP on healthcare compared to the OECD average of 9.2%. This translates into over $12,000 spent per person, more than double the OECD average. High administrative costs are pervasive in the US health system due to the large private system for the payment, insurance, and delivery of healthcare. This is a complex yet fragmented system where there is very little integration or coordination among players. As a result, administrative costs make up over 7% of total healthcare costs in the US compared to an OECD average of 3.7%. Despite spending so much on healthcare, American health outcomes are not significantly better than OECD counterparts. Life expectancy in 2021 was 76 years, which is 4 years lower than the OECD average, while US infant and maternal mortality rates exceeded the OECD averages. And for many other health outcomes shown on the chart on the right, which includes several indicators for the quality of primary and acute care, you can see that the US ranks somewhere in the middle or lower of the pack among a range of other countries. The United States' complex and fragmented health system has resulted not only in high costs, but also unequal healthcare access. The US currently does not have a form of universal health coverage. Although 92% of the population is covered for a core set of services, the 8% of Americans that are uninsured do not have access to primary care unless they can afford to pay entirely out of pocket for the costs of care. For Americans with health insurance, about 66 are covered under private plans, while 36% are covered by government insurance programs including Medicaid, Medicare, and CHIP. However, Medicare for the elderly provides limited coverage for dental, vision, hearing, and prescription drugs. Medicaid enrollees must qualify based on income restrictions which differ from state to state. An estimated 1.5 million uninsured Americans fall into the Medicaid gap, where they earn too much to qualify for Medicaid, but not enough for the ACA marketplace assistance. The ACA tried to expand Medicaid by providing federal subsidies to states that expanded their Medicaid eligibility requirements, but not all states have done so. For those Americans covered by private insurance, the high deductibles and high co-payments can result in large out-of-pocket expenses that make healthcare essentially unaffordable for many. This population of underinsured Americans is estimated to total 25 million non-elderly individuals. Healthcare disparities in the US persist along several racial and socioeconomic factors. For example, Black and Native American people have lower life expectancies on average, higher infant and maternal mortality rates, and are at higher risk for many chronic health conditions. Black Hispanics and Native Americans also have higher uninsurance rates, as do immigrants and low-income families. In addition, rural areas, there are people who face barriers of care due to a lower density of providers and greater distances needed to travel. There are many factors contributing to these healthcare disparities. For example, many people of color live in areas with high levels of poverty, crime, pollution, and unequal access to education. The COVID-19 pandemic highlighted some stark contrasts in health disparities in the US and led to a renewed focus on tackling these issues. The Biden administration passed a series of executive orders to address health equities, including one that identified equity as a government priority. The Department of Health and Human Services has developed a health equity plan to address increased maternal mortality rates among Black and Native American women, structural racism in biomedical research, and issues related to strengthening patient protections, among other initiatives. So traditionally, the role of government in the U.S. health system is subsidiary to that of the private sector. This is in contrast to many other developed nations where the government plays a central role in healthcare. The private sector is the dominant player in the U.S., so the government is largely left to fill in the gaps left by the private sector. In this role, the government does provide some health safety nets for vulnerable populations. We have already mentioned Medicare, a government program that covers Americans over the age of 65 and low-income individuals with disabilities. Medicaid, which covers those under a certain income, and eligibility is determined by the states. And finally, CHIP, or the Children's Health Insurance Program, which provides insurance for children in low-income families that do not qualify for Medicaid. The U.S. has also established federally funded community-based health centers across the country to provide primary and preventative care to rural and urban underserved populations. However, access to federal health care center varies, and many of them are overburdened with high demand. So overall, the health safety system, um, the, the health safety net in the U.S. is not a secure one. Other health safety net services for private sector providers might be free clinics or other services provided at a physician's office or hospital outpatient department. Many who cannot afford healthcare wait until problems arise and seek treatment at hospital emergency departments. The Emergency Treatment and Labor Act of 1986 requires hospital emergency departments to evaluate and provide necessary stabilizing treatment and admittance to every patient, regardless of ability to pay. So many uninsured Americans can receive acute care from the ER. However, heavy use of the ER for non-emergencies from both uninsured and insured populations has resulted in overcrowding and a waste of resources. The overuse of the ER, especially by those without routine access to care, is also a contributor to the US's poor health outcomes and high health care costs.
Hello, my name is Patricia, and I am working on the cost, quality, access, and equity portion. To start off, strategies to contain cost would be more programs like the ACA, which was created to increase the affordability of healthcare, and that was done by focusing on reducing cost and lowering uninsured rates. Strategies to improve quality would be to vouch for more integration of the system to help streamline processes and combat the effects of not having a uniform system and the product of falling through the gap. Other strategies to reduce health discrepancies would be to introduce more mechanisms like mandates that assist those that are affected by the gap in healthcare and provide subsidies to help with healthcare related costs, and of course, encourage health insurance exchange. Some notable healthcare market activities would start with the health system consolidation. So the ACA was passed into law in 2010, and it was made to create one marketplace where affordable options dash alternatives could be made for health insurance and made available to the general public. This resulted in improving healthcare accessibility and mitigating costs. For private equity investments plays a growing and significant role in the financing of healthcare in the United States. In a 2022 Estimate about 863 healthcare related service deals were closed because of private equity firms. After that, reaching a peak of 1,013 transitions in 2021. So, the shift in locus of care, seems to be a push to shift from acute care, which is inpatient care, to ambulatory care, which is outpatient care. This shift to ambulatory care produces faster access for people and shorter stays, which of course translates to lower costs for patients.
Hi, I'm going to talking about notable innovations. The model I'm going to introduce is value-based care models. This model has several advantages across the different aspects of healthcare. They aim to reducing the cost by focusing on outcome and efficient, improving quality of care by prioritizing patient satisfaction and effectiveness treatments. That to access to the healthcare services, those through the activity like telemedicine and promoting equity and addressing healthcare disciplines and ensuring fair resources allocation. Overall, those models represent a comprehensive approach to healthcare delivery that benefits patients, providers, and healthcare system alike. There's a few challenging talking about multimodal therapies. One downside of multimodal therapies is they're adding complexity to treatment, combined with medication devices and behavior interactions, making managing treatment plan trickier. It's hard to figure it out the right doses, timing, and other therapies, leading to potential interactions and side effects. Getting a multi-month therapist developed and improved is also tougher and takes more time to compare with single treatments. Regulations want actual proof of their safety and effectiveness, which can drag out the approval process and definitely would add up to the cost. On top of this, using multi-month therapists can run into roadblocks. With insurance coverage, payers have different rules for what they are covered, which can make it through the patients to access the treatments. Overall, while the multi-month therapist promise with a better outcome by targeting more aspects of the condition, they also came with some challenging need to be carefully handling. This is innovation example. The case was talking about developing multimodal therapies for brain disorder. The therapist combines different treatment like medications, devices, and behavioral interventions to optimize brain disorder treatment. Understanding disease process is a key for their development, but they also pose challenging like scarcity trial effectiveness and providing their combined efficiency across various healthcare contexts.
Thanks. Like much of the United States, the American healthcare system is largely built around individual rights and responsibilities working in a free market. This is a double edged sword that can lead to incredible new innovations and the most advanced, highest quality care, but it does not immediately lend itself to addressing issues of access or equity. The various states serve as testing grounds for democracy, and state healthcare largely follows suit. Because of this, the American system is evolving but fragmented. There is a need to reduce costs so more Americans can afford health care and provide a safety net for those who can't. The Affordable Care Act is still new, and its effects aren't fully understood yet. In the run up to the passage of the Patient Protection and Affordable Care Act, two of the biggest concerns regarding the American multimodal healthcare system revolved around cost and access. The United States spends more of its GDP as a percentage on healthcare than any other nation in the world, including the other advanced economies. While Canada, the UK, and others are increasing their spending to provide timely access to essential services, including surgery, the US still spends more per capita. The quality of care has been described in multiple ways. It is generally recognized that those with the financial means, either through insurance or out of pocket, are able to get fantastic care. Unfortunately, those with lesser means often don't get this same high quality care. These mixed outcomes result in overall average care compared to the other developed nations. Before the passage of the Affordable Care Act, the US already had a form of catastrophic coverage that included the uninsured. The Emergency Medical Treatment and Labor Act of 1986 required hospitals with emergency rooms to provide acute care regardless of the ability to pay. This led to a focus on acute care rather than health maintenance. Access further expanded when the Affordable Care Act passed with an individual mandate to purchase health insurance. However, the penalty for not having minimum essential coverage has been removed. The employer mandate and guarantee issue remain in effect. The number of uninsured Americans is at an all-time low. However, there may still be the need to create a safety net for those who need coverage but can't afford it. Healthcare access and outcomes are unevenly distributed across the U.S. for a host of reasons, including financial, location, and individual lifestyle choices and behaviors. Some of these inequities can be addressed through free market means and lowering costs, while others may need some government intervention. Directly addressing one of these issues can have an impact on the other areas as well. Current pricing methods are opaque. In a free market, patients should have information about price and quality of each provider. Removing barriers to transparency would be a simple way to reduce costs. This would also improve the ability of payers, either public or private, to negotiate on price and further lower cost. Additionally, having insurance cover the cost of basic and routine care actually undermines the principle of insurance. Normalizing health savings accounts for routine care would reduce the cost of insurance for major unforeseen events. HSAs would also move chronically ill Americans away from emergency rooms and into the offices of primary care physicians for routine health maintenance. This will improve quality for chronic conditions and reduce wait times in overcrowded emergency rooms. Filling in the gaps in coverage through charity care or means-tested government funding will complete the safety net for those who want health insurance but can't afford it. While access to health insurance is not the same as access to care, insurance and an HSA will remove an important hurdle to universal access. Equity can be improved in that most American of ways through technology. Telehealth would allow Americans from all locations and all walks of life the ability to see top expert physicians from anywhere around the country. No longer would access or quality be determined by zip code. A farmer in rural Illinois could use telemedicine to see a world-renowned expert at Johns Hopkins and receive the same quality of care as a sophisticated city dweller in Baltimore. While innovation can be expensive at first, the American system is defined by rapid diffusion of new technology, which is more equitable as more people gain access. Market transparency, individual health savings accounts, and a means-tested social safety net can lower costs, improve quality and access, and make the American system more equitable in a user-driven and government-aided as needed multi-model system. This would improve the system while remaining culturally and contextually appropriate for a country that values individual rights and responsibilities.
The American healthcare system offers insured patients the greatest level of access to see specialists compared to anywhere in the world. If you live within the United States and you have access to sufficient healthcare coverage, you have the opportunity to see a wide range of specialists in any given area. However, it is important to note that this access does not always apply to those who are underinsured. Individuals who are underinsured or not insured very often do not have that same level of access. However, for those who are considered fully insured or sufficiently insured, this is something that is definitely innovative. And again, it's not having specialists because many developed nations have access, to specialists. It's the wide range of specialists that Americans or people who are in the American healthcare system have access to. Additionally, because the United States has such a significant economic power and raw materials just based on its physical and geographical size and nature and expansive reach, this has allowed the United States, and when we go back to the COVID-19 pandemic, the United States was able to contribute $2 billion to developing a vaccine within 1 year. And it's important to note that the United States was not alone. But the United States had the financial resources to contribute funds to Pfizer and biotech, as well as Moderna and Johnson & Johnson, to not only promote a little competitive nature, but also to pour those resources into a company that could develop a safe vaccine in the shortest amount of time possible. Again, that is something that's highly innovative, and that's just having those access to those financial resources allowed the United States to be able to do this. And then finally, I would say the United States American healthcare system prides itself on the freedom of choice. For insured individuals, they can choose their own physicians, right? You can choose the hospital that you want to go to. You can choose locations to have your prescriptions filled. This is not always the case, even in our most developed nations, right? As we've learned about other models. And so this is something that I would definitely say is innovative. This is something that does set the United States apart. You look at the number of locations when we look at pharmacies, right? You can go to the grocery store and have your pharmacies filled, have pharmacies delivered to your home in the mail, have pharmacies filled when you're at a doctor's office, at the clinic, at a hospital. There are so many areas that we have available to us. But it's important to note that for individuals who are underinsured or uninsured, that level of access is not there when you compare it to individuals who are fully insured or sufficiently covered.
These are references we used, and thank you so much for your attention.